Our special guest today hails from the Emerald Isle, the land of legendary leprechauns, four-leaf clovers, the Barney storm, no snakes, and of course Guinness. He's Dr. Gerard Morton. He's professor of radiation oncology at the University of Toronto and an adjunct professor of physics at Ryerson University. He has been a staff radiation oncologist at Sunnybrook since 1995. He has had a large part to play in developing new and better treatments for men with prostate cancer and has published over 150 peer-reviewed papers on the subject. He went to medical school in Cork, Ireland, that's the Republic of Ireland, not Northern Ireland, and he completed most of his postgraduate training in Dublin before moving to Canada.
Yes.
He's a keen long-distance runner and a kayaker, and he and his wife look forward every year to spending time camping and associating with the black flies and mosquitoes in the great Canadian North. This summer, they plan once again to escape to Lake Superior for a couple of weeks away from electronics, cell phones, and modern communication devices, but I'm sure they'll take the GPS with them, just to make sure they don't get lost. So without further ado, I give you Dr. Morton.
Thank you. Thank you very much, Keith. I hope you can hear me okay.
I can hear you.
That's great. You know, it's a pleasure to be invited to speak to everyone once again. I know it's been a few years, and I find this actually a little intimidating, I got to be honest, because I've never had so many men up on my computer screen before that I've done a digital rectal examination on. So this is sort of a new experience for me as well. So let me just see if I can bring up some slides. Let me just see. So thanks for the invitation to speak. And what I was asked to talk about was 25 years in prostate cancer care, where we were, and where we were heading. And obviously the reason that I was asked is that I'm one of the few people around at the moment who knows intimately what it was like to be treating prostate cancer 25 or more years ago, because I was obviously doing it then. This actually is an advertisement I saw in yesterday's paper, and it seemed to be opportune because it was asking about technology. It says technology has changed a lot since 1996, and you know that really got me thinking, because 25 years ago certainly our technology was quite different from what it is today. So what I'd like to do over the next 45 minutes or so would be to explore how new tools, technology, and treatments have improved the outcome for men with prostate cancer, and maybe have a peek into the near future. Now, this was, you know, when I was asked to speak on this, I said, yep, sure, sounds great. But when I started thinking about it, this actually is a lot tougher than you might imagine, because there's so much to talk about over 25 years. There's no way I'm going to even do any part of this justice. So this is going to be a very superficial look at some of the things. So certainly over 25 years, a lot has changed, but you know, a lot has remained the same. And it's interesting, if we look at the maple leafs from 1995, 96, so 25 years ago, have things changed? Well, they were in the maple leaf gardens back then, but look at their score sheet at the bottom. So red are losses, greens are win, and you know, that looks very similar to what we're used to seeing in more recent years. So no great change then. So, but some things have changed. You can see our good Prime Minister here. He certainly changed. Some things, in fact, have even changed for the better over 25 years. And this is what's happened to computer technology since 1996. And I'm very glad that I'm not trying to do this Zoom broadcast over my old Macintosh Classic 2 from 25 years ago. I think we'd have problems. I much prefer to be using a modern machine like you see on the right. And probably the biggest difference that most of us would be aware of is changes in cell phone technology. You know, 25 years ago, guess what a phone was used for? It was used for talking to people on the phone. And current phone, Genie, you know, it's hard to know what you can use them for. You can use them to start and probably drive your car, to control your house, to watch movies, make movies. I think you can probably use them to make a phone call as well, but sometimes it's hard to figure out how to do that. So just a reminder of what the prostate is and where it is and what the function of it is. So the prostate is this very troublesome small organ that sits just beneath the bladder, as you can see in the diagram. And what does it do? Well, apart from causing us trouble, its main function is to produce semen, because the prostate is full of these glands and ducts that you can see illustrated as well. These make semen, which then is ejaculated in through the urethra down the penis, which you can kind of make out. The other function it has is a muscular function, because it has a lot of muscle tissue as well, especially around the bladder neck and around the bottom of it, that's called the apex. And this helps control bladder emptying. So if the prostate is removed, you might imagine no more semen is going to be produced, and there may be some problems with bladder control as well. Now, prostate cancer, despite its small size, is the organ in the body that's most prone to misbehave and become cancerous. And cancers originally start as small areas within the prostate that you can see illustrated on the left initially. If it's really small and you can't see or feel it, it would be called a T1 or stage 1 cancer. If it becomes a bit more of a nodule, something a little bigger like this, it's a stage 2 cancer. Both of these are confined within the prostate. They tend not to spread beyond. If it gets a bit bigger, a few bad things can happen. It can extend into some of the surrounding tissues. In really severe situations, can go back and invade the rectum behind, or invade the bladder, causing problems. The worst thing that happens, of course, is spread. And spread or metastasis from the primary cancer can occur. And it can spread to lymph nodes, which are little filters usually around the blood vessels and the pelvis. And from there, they can spread to other parts of the body, such as bone or lung. And in fact, prostate cancer can also spread directly to bone or maybe lung through the bloodstream. So it stays in the prostate initially, but as it continues to grow, it can spread either to lymph nodes or to other parts of the body. This would be called distant metastasis or nodal metastasis. Now, this is a reminder of what prostate cancer was like in the bad old days when I first left medical school. So I finished medical school in 1985. And prostate cancer at that time was always bad news, because it was only picked up after it had spread and was causing symptoms, usually pain because of disease in bone. What you see here is a bone scan. This is actually of a 52-year-old man who was feeling very well, was otherwise healthy, but complained of some pain in his right thigh. And this is his bone scan. Now, a bone scan is a way of looking at the bone. You can see the vague gray outline of the normal skeleton, but all these black dots and black areas, and in particular this big black patch in his right upper leg, represent areas of cancer spread. He'd never had a PSA previously. When he did do a PSA, it was 2,748. So he presented with metastatic disease causing problems. We'll come back to this again later in the talk. Now, we don't want to be picking up cancer at this stage. We want to pick up prostate cancer early, before it has spread, while it is still localized to the prostate. Because while the cancer is still confined to the prostate, before it has spread, we've got an opportunity to get rid of it and stop it from spreading in the future. The two main ways of treating it would either be to remove it, that, as you know, is called a radical prostatectomy, or to treat with radiation, which directs a big dose of radiation onto the prostate, thus killing off the cancer cells in the prostate. Take a look at what has happened over the last 35 years in prostate cancer incidence, which is the blue line on the top, and mortality, which is the red line at the bottom. Now, incidence refers to the number of new cases of prostate cancer that are diagnosed every year. And what you can see is that it's, up and down quite a bit. It looks like a mountain range. You can see in the early 90s, there was a huge peak in incidence of prostate cancer. Then early 2000s, you can see increase once again. So the incidence was quite high and gradually increasing for quite some time before a gradual decrease in the last 10 years or so. What is interesting, of course, is the mortality. And mortality refers not to the number of new cases, but the number of men who are dying from prostate cancer. And really interestingly, you can see that the death rate from prostate cancer has halved over the last 25 years. So in 1996, there was about 45 men per 100,000 were dying every year from prostate cancer. And that's down to 21. So this is a huge change. So the number of Canadian men dying from prostate cancer has halved over the last 25 years. This is a huge success and something really to be proud of. It begs the question, of course, as to why. Why has prostate cancer mortality improved so much? And I think, there are three main factors responsible for this. One is we've been finding cancers at an earlier stage when it's more treatable. We have better treatments for cancer that's localized to the prostate. And we also have better treatments for cancer that has metastasized for advanced disease. So, first important thing that's happened over the last 25 years is that we've been finding cancers at an earlier, more treatable stage. Not like the first man that I showed you who only presented late when the cancer had spread. And the reason for this, of course, is PSA testing. And I know this is a topic that's near and dear to many of you, but we've had increasing use of PSA testing since the early 1990s, and this has resulted in a huge increase in the number of early, potentially curable prostate cancers that we have detected. So here's the incidence curve once again, and what you see from 1985 right up to about 2008, a gradual steady increase in the incidence and the number of new cancers detected. Since then, though, there's been a significant decline. So a more gentle decline starting around 2008, 2009, and then a more steep decline after about 2012. Now, is that because men aren't getting prostate cancer anymore? I don't think so. It's probably because they're not having PSAs checked, and there's a lot of cancer lying there that we're not picking up. So to help us understand why that's happened, let's go back a few years. Let's go back to 2009. And this is when two large, what were called randomized clinical trials were published. These were looking at the value of PSA screening, and they were both published on the same day in the premier medical journal called the New England Journal of Medicine. One was an American study, and the second one was a European study. And this is what the Toronto papers made of these two studies the following day. André Picard, the health writer in the Globe and Mail, very confidently stated that the prostate study claims PSA tests will save more lives. The Toronto Star, though, took a contrary view, even if in their spread they had this photograph of a really handsome radiation oncologist. However, they were less enthusiastic about PSA, and their conclusion was that a common and increasingly popular prostate cancer test does not reduce a man's risk of dying from the disease. The Toronto Sun, the third paper, waited until the following day before discussing this, obviously looking at the headlines on the other two, said prostate studies prove inconclusive, which is probably a very reasonable response. Here's what the studies show. The first one was the US study, and this took a large number of men, almost 77,000 men from 10 centers in the United States, and half of them had PSAs annually and a DRE. Our control group that just had standard care. Now, the big problem, of course, is that Americans have a different idea of what standard care means, because most of them ended up having a PSA done anyway. So surprise, surprise, if you're doing PSAs in both arms of the study, you're not likely to find much difference in the prostate cancer mortality and the risk of dying of prostate cancer, because both of them had PSAs done. The Europeans were a little different. This is a much larger study, over 180,000 men from 7 different countries. And they just had PSAs drawn every 4 years, or the control group. And the control group here did not tend to have PSAs done regularly. Now, the chance of picking up prostate cancer was twice as high in the group that had PSA. But here's the thing, their risk of dying from prostate cancer was reduced by 20%. So very strong evidence that PSA testing can save lives. To complicate matters further, there was an analysis done and a report by what was called the US Preventive Services Task Force. And they first issued a report in 2008. Remember when the numbers of men having PSA testing started to decrease. They said men over 75 should not have a PSA test. And men younger than 75, well, they weren't sure. They felt on balance, it was undecided, it might be a good idea, might not be a good idea. But 4 years later, they came up with this very dangerous conclusion and recommendation that doing PSA screening for prostate cancer was a bad idea, and in fact did more harm than good, and recommended against anyone doing PSA screening. Naturally, there was a lot of concern about this recommendation. And this can be seen in the CBC headline at the time. The urologist, the PSA test should be abandoned as screen for prostate cancer, the task force says, but recommendation undoubtedly will lead to more prostate cancer deaths, the urologist counters. And there is some evidence that that's probably the case. If we look at the stage of men who are being diagnosed with prostate cancer before and after these recommendations, you can see that very few men had nodal or metastatic spread of cancer when PSA testing was commonly done. But as the number of men who had PSA screening decreased, the chances of being diagnosed with metastatic disease increased. So there was a huge increase in the proportion of men who were diagnosed with metastatic disease after introduction of these guidelines. And this is a very recent report. It was presented just a few months ago at ASTRO, where the American situation was looked at in quite a lot of detail. And the graph on the left looks at the frequency of PSA testing in different states. Each of these lines is a different US state. And you can see that after about 2010, there was a big decline in just about every state in the proportion of men over 40 who had a PSA screen. And guess what? Shortly thereafter, there was a significant increase in the number of men in each of these states diagnosed with metastatic prostate cancer. So lower levels of PSA screening was strongly associated with increasing amount of metastatic disease. And those states that had the largest decline in PSA screening had the greatest increase in incidence of metastatic prostate cancer at diagnosis. The most recent report, recommendation, from the US Preventive Services Task Force is probably a little bit better, but once again, recommends against screening for prostate cancer in men over 70, and has a very lukewarm statement about screening in men aged 55 to 69, saying that the decision to be screened should be an individual one, really not coming down one way or another. So what does this mean for the future? Well, we've seen this earlier. We've had great success. So this rising incidence of prostate cancer due to PSA screening in Canada has been associated with a halving of the death rate from prostate cancer. It does take several years for this effect to happen. In the last 9 or 10 years, we've seen a significant drop in the number of men who are having PSA screening and the incidence, the number of new prostate cancers that are being detected as a consequence. And the question really remains as to what effect this is going to have in the future on mortality. So in the last 25 years, PSA screening has been a huge success, and it's helped us find prostate cancer at an earlier, more curable stage. I think it's fair to say that there still is a lot of confusion around PSA testing. Family physicians who primarily order PSA testing are getting conflicting messages. And as a result of the decreasing use of PSA testing, we're seeing increasing amount of metastatic disease at diagnosis, which does not in itself bode well for the future. So I think groups such as this can, hopefully advocate for maybe some changes in how we screen and look for early disease. Excuse me. So the other factor that has improved mortality, significantly reduced mortality, is better treatment. So we have a better understanding of how prostate cancer behaves. We know which cancers need to be treated aggressively, which cancers we can watch, which cancers need sort of moderate type of treatment, moderately aggressive treatment. We've had huge advances in radiation treatment technology. And like, when I was asked to talk about this, well, this is what I do. This is what I wanted to focus on in particular, but I restrained myself, and I'm not going to say too much about it because I'd be talking all night if I did. But the sort of changes and advances parallel the changes that we've seen over the last 25 years in every other type of technology. We've seen how our cell phone and our computer has adapted and changed over this time period. These sort of technological changes are now incorporated into better ability to see and identify where prostate cancer is and tailor treatment and give better treatment more precisely and with less side effects to men. We also now know that adding treatments such as hormone therapy to radiation therapy improves survival. And I know earlier on, before this meeting started, there was a lot of discussion about androgen deprivation therapy or hormone therapy and how bad a thing it is and how awful it is, to be honest, and I completely agree. On the other hand, it probably is the reason that a lot of men are alive. So one thing we know is that we don't need to treat all prostate cancer right away. 25 years ago, we had a tendency to treat everybody with prostate cancer, and this certainly was not a good way to manage cancer because we were over-treating many men who never needed treatment. The group in Sunnybrook, led by Dr. Lawrence Klotz, my old colleague, Richard Chu, who I know is known by some of you here, and my other colleague Cyril Danjou put together this idea initially of active surveillance for men with low-grade prostate cancer. And we started looking at men with what appeared to be early stage, low-grade, non-aggressive type prostate cancer and monitoring them instead of immediately treating them. And this seemed to be very safe. So we've been doing this for the best part of 25 years now. And the 10 and 15-year survival for men managed without immediate treatment seems to be excellent for those with low grade, also called grade 1 or Gleason 6 prostate cancer, with 15-year survival of over 95%, which is really spectacular. So we've shown since then that a policy of initial monitoring and selectively treating those who progress is safe and spares many men the side effects of upfront treatment. Many men, however, do need treatment, and we found that the most important predictor of how a cancer is going to behave is the biopsy finding, and in particular, what's called the grade of the cancer. So this is something that's found when the pathologist looks at the biopsy of the prostate. So as you know, when the PSA is elevated, typically someone would then have a biopsy of the prostate, not the most comfortable or pleasant of experiences. The pathologist will then look at the biopsy and assign a grade. And the higher the grade, the quicker the cancer tends to grow, and the more likely it is to spread beyond the prostate. So it's a very important feature of a prostate cancer. In the past, we used to describe this using a very confusing scale called the Gleason score. Thankfully, this is being replaced by what's called an ISUP grade group. This has been around for the last 11 or so years. Published, you can see here in 2014. So the grade group describes prostate cancer appearance on a scale of 1 to 5. 1 is the best, grade group 1, which corresponds to the old Gleason 6. Then there's a grade group 2, 3, 4, and 5 being the worst. And this seems to be a very strong predictor of how prostate cancer is going to behave. What this graph shows is the chance of cancer recurring in a large group of over 8,000 men who were managed with radical prostatectomy. And you can see following radical prostatectomy at a center of excellence in the States, if they had grade group 1 or Gleason 6 cancer, they did very well. And similarly, grade group 2 or good Gleason 7 cancer. Again, they could expect 88+% of men to be still free of cancer 5 years later. Grade group 3 don't do so well. And grade group 5, which would be Gleason 9 or Gleason 10 cancer, do really badly after radical prostatectomy. And as you can see, going out to 10 years, very few of them would still be disease-free after having their prostate removed. So this is a very useful way of trying to counsel a patient with newly diagnosed prostate cancer as to what sort of outcome they might expect after treatment and how aggressive the treatment needs to be. So clearly, low grade group 1 and 2 seem to do quite well with simple treatments, but certainly when we get into these more aggressive cancers, a more aggressive treatment is going to be warranted in order to give them the best chance of staying cancer-free after treatment. Now, the goal of radiation treatment is to deliver a high dose to the cancer with as little dose as possible to surrounding organs. And, just trying to think of what sort of analogies there are between changes and advances in radiation treatment and over the last 25 years. I think auto technology is a pretty good analogy. You know, going from a very simple, basic stick shift car in the past to something now that can do pretty much everything even on its own. It very high tech. It can drive for itself. It can see where it's going. So a very different animal compared to what was around in the past. Interestingly, exactly 25 years ago, Sunnybrook had the first what's called CT simulator in Canada. And this is a special type of CAT scan, which allowed us to use images, CAT scan images, to see where we needed to treat. And this is an example of images we got back in, I think it was 1997. And what you see here is the outside of the body from the CT scan. You can see where the beam of X-ray might need to go, shaped nicely to the shape of the prostate. And looking inside, we can do our cutaway. We can see the prostate, the bladder, the rectum, and this shape is going to conform to the shape of the prostate. And we're able to do this from a number of other angles, delivering a big dose to the prostate with quite a lot of sparing of the other organs. So this was called 3D conformal radiation treatment, shaping the beams to conform to the shape of the prostates. And this was state-of-the-art treatment in the late 1990s, early 2000s. In 2001, Sunnybrook had another first, and that was using a newer type of radiation technology called intensity modulated radiation treatment, or IMRT, to treat prostate cancer. It's very similar in many ways to 3D conformal, except in addition to shaping the beams, the intensity of radiation along all these beamlets was changed as well, just to allow even greater concentration of the high dose where it's needed in the prostate itself. And this is very similar to what we still do currently. It's we use slightly different letters. Instead of it being called IMRT, we call it VMAT, or volumetric arc therapy. But the concept is the same, except instead of having, as in this case, 5 beams or sometimes 7 beams, the machine will move around continuously, changing the intensity of the beam, being super precise at targeting the prostate and minimizing spillage of radiation to other organs. Of course, having nicely shaped beams would be no good unless it's directed at the right target. So hand in hand with these developments comes image guided. So this is again given an acronym of IGRT, or image guided radiation therapy. This is what an external beam radiation machine looks like. In Sunnybrook, this would be a modern machine. X-rays come from the head of the machine. The patient lies on the couch here. Beams would be shown from different angles. They would move around. But more importantly, at the same time, there's this other system, which is integral to it as well, which actually takes a picture and looks inside the body to make sure that the prostate is correctly positioned on each treatment occasion and can adjust the beam. So it's using technology to be able to make sure the target is right in the crosshairs of the beam. So this would be image-guided radiation treatment using VMAT, which would be current state-of-the-art radiation treatment. So what's the effect of all this technology change? Well, one very real effect is that it has made radiation treatment a lot more convenient for patients. We're able to see the target and safely deliver high dose of radiation in fewer and fewer treatments. Not that long ago, if somebody was having radiation treatment for the prostate cancer, I'd be saying to them, okay, I'm going to be seeing you. You're going to be coming here every day for the next 8 weeks. 39 treatments was the standard, and this is called conventional fractionation. 39 treatments. Some 5 or 6 years ago, a number of clinical trials showed that we could get the same results in 20 treatments over 4 weeks, so half the length of time. So instead of giving it over 8 weeks, we could do the same treatment in 4 weeks, giving a little higher dose every day, but the results were the same. The cancer control rate was the same. There was no increase in side effects by doing so. And the most recent advance is to reduce this from 20 treatments to 5 treatments. So if you're coming to Sunnybrook today for external beam radiation treatment, most men would be treated with a protocol of just 5 fractions delivered over 2 weeks. And this is called SBRT, which stands for stereotactic body radiation therapy, or SABR, which stands for stereotactic ablative body radiotherapy. I know a lot of my colleagues like the SABR stuff because it sounds cooler. But the meaning is the same. This is giving a very high dose every treatment for 5 treatments, usually every second day over 2 weeks. And this is used if we're just targeting the prostate. Often it requires an initial step for us to put some gold marker seeds in, because we need to be super precise if we're giving such high doses of radiation, not to also treat normal tissue in the process. And the most recent piece of technology in Sunnybrook is what's called an MR-Linac. And this is a really interesting piece of technology which combines a radiation treatment machine called a linear accelerator. It's represented by this little thing here, which rotates around, with an MRI machine. So an MRI is a way of looking inside the body, and it gives us very precise pictures of the anatomy. So combining an MRI with a linear accelerator, and this is a photograph of our unit, allows us to get a very great precision in delivery of the treatment, making sure that the prostate is exactly where it is, and also can adapt on a daily basis to any changes in the prostate size and shape that might occur over the course of treatment. There's a photograph of the first prostate cancer patient treated in Sunnybrook. Well, this isn't the patient, this is the excited team outside. Some of you may know Dr. Vesprini here, who I think was looking after the very first man treated on this. And this was dated November 2019, so just pre-COVID. So a lot of advances in external beam technology. The other big advance is in internal radiation, which is called brachytherapy. So this is a way of giving radiation, not by shining beams from the outside, but by putting the radiation right into the prostate itself. And this allows us to get the highest possible dose of radiation to the cancer. You can see this is a little diagram showing how it's done. Here's the prostate. The patient is asleep for this. Don't worry, he's not feeling any pain or discomfort. He's dreaming of some pleasant thoughts. Here's the prostate. We use an ultrasound in the rectum, similar to what might be used for someone having a biopsy. And we then put some needles into the prostate. And through these needles, we can do one of 2 things. We can insert the needle. This is a photograph of an ultrasound in someone's rectum. Use this grid system, a bit like Battleship, to put some needles in the prostate, through which we put these little tiny radioactive seeds. And these seeds stay there permanently, slowly giving off radiation treatment. And Sunnybrook was one of the first centers in the country, once again, to offer prostate brachytherapy. And our first case was treated in January 1998. A slightly different way of doing brachytherapy is a temporary type of brachytherapy called HDR, or high dose rate brachytherapy. It looks very similar. We again put needles into the prostate. These are needles in place. We use an ultrasound so we can see all these little white dots. These are a cross section through the needles in the patient's prostate. And instead of leaving seeds, these needles are then connected up to a radiation machine, which will send a radioactive pellet one by one down these needles. And it's programmed to stop in different positions for different lengths of time to deliver the radiation dose. It takes maybe 10 or 15 minutes to actually deliver this treatment. And once that's done, these needles are removed, patient wakes up and is usually able to go home 1 or 2 hours later. So 2 different ways of doing something similar. And why do we like doing this? Well, because it works really well. And the clinical trial, the randomized studies have shown that if we combine brachytherapy with external beam, we get much better results than treating men just with external beam only. And that's because we're giving a much higher dose of radiation. So cancer care guidelines, Cancer Care Ontario guidelines, ASCO, which is the American Society of Clinical Oncology, have published guidelines 4 years ago, stating very strongly that when men with higher risk prostate cancer are being treated with radiation, they should be offered brachytherapy as well, rather than just external beam on its own. So brachytherapy plus external beam seems to be better than external beam alone. The other advance and the other reason that men are being cured and living longer than before is use of hormones. And I know we mentioned earlier, this is a sore topic with many men who are on hormones, have been on hormones because of the side effects that can be lasting even after the hormones have finished. But this was the reason why you've been on hormones with radiation. The studies show that if you have hormones for some period of time, this particular study used hormones for 3 years after radiation, but maybe we don't need to use 3 years, but if you're on hormones for some duration with the radiation, your chance of being alive and well 10 years later is going to be significantly higher. Now, in addition to improvements in technology delivering radiation, we've also had huge improvements in our ability to see where the cancer is. So what you see here is an MRI scan of the prostate, which is able, once you know what you're looking at, to identify this small area of cancer measuring just 7 millimeters on the right side of this person's prostate. So you can see the cancer. This is the same patient. And you can see this colored area in the prostate, which corresponds to the area of cancer. This is what's called a PET scan, and in particular, a thing called a PSMA PET scan. So PSMA is a substance that's injected a bit like a dye, and it goes around the whole body and concentrates in areas of prostate cancer. Now, it can go to a few other areas as well. It can go to the salivary glands, it can go to the liver, it can go to the kidneys and be excreted in the urine. So if you see it there on the scan, that doesn't mean anything. But if you look at this patient's prostate, if you squint, you can see there's uptake in the prostate as well that corresponds to this little 7 millimeter lesion in his prostate, indicating that that's where the cancer is. So this, of course, begs the question that if you can very accurately identify where the prostate is, well, maybe you can do something different. Again, the same patient, instead of giving a big dose to the whole of the prostate, we're able to use brachytherapy and concentrate most of the dose just here in the area where the cancer is. So higher chance of cure, less chance of side effects. And in fact, a big randomized trial doing something similar, except with external beam, has recently been published. This was published in very recently, 2021. So it's a very recent report where men were randomized to conventional radiation treatment over 8 weeks. The whole prostate, which would be standard, are the same with a boost given just to the area of cancer identified on MRI. And you can see that the chance of being disease-free is much better with this extra dose to the nodule. Question we get asked all the time. Well, okay, I've got a cancer, I've got a high-grade cancer, it needs to be treated. Should I have radiation alone, Should I have radiation and brachytherapy? Should I have radical prostatectomy? And this is probably the best piece of information we have to help us answer that. This is a study of over 1,800 men with the worst type of prostate cancer, grade group 4 and 5. Remember when we used prostatectomy alone? Most of these men ended up recurring. So outcome was looked at depending on whether they had prostatectomy, which is the dark green line, external beam radiation alone, the orange, or external beam combined with brachytherapy, which is the blue line. And you can see that those who had the external beam plus brachytherapy had a much higher chance of being alive at 10 years compared to either of the others, and being free of metastasis. So what does this all mean for us in the clinic? Well, anyone with high grade cancer, so grade group 3, 4, or 5, be considered for radiation treatment. Should also have a discussion about brachytherapy and hormone treatment. For those with grade group 2 cancer, lots of options, and they do very well either with surgery or brachytherapy or 5-fraction external beam. And for grade group 1, we've learned that most of these men should probably be managed with surveillance. Here's what's happening in Ontario over the last 10 years or so. You can see that the number of men having radical prostatectomy has decreased quite a bit. In fact, it's down 30%. And in place of that, men are having radiation more often. And the reasons for that, well, probably because we now have really good long-term results using radiation, especially modern types of radiation. And more men are seeing a radiation oncologist at the start. So advances in radiation treatments have allowed us to treat prostate cancer with far fewer treatments, improve cancer control, and improve survival. The final thing I want to talk about, and this is going to be really brief because I know you've had talks already from my colleague, Dr. Emmenegger, and others who can do a much better job of discussing this, and this is a huge, huge topic on its own, is advances in managing men who've got metastatic disease. So remember the patient we talked about at the start, widespread metastatic disease. Really the only treatment open to him at the time was hormone treatment. And I know many of you would be familiar with these type of drugs, Zoladex, Lupron, Eligard. There are others. They all work exactly the same way. Maybe adding in an anti-androgen, something like Casodex. What would happen is this initial treatment with hormones often works for about 2 years, maybe a little longer in some cases. Then the cancer continues to grow. It becomes resistant to this treatment, and there are very few other options available to them. All that has changed. Today, there are new generations of hormone treatment that work much better and are much more effective and improve survival compared to the old standard treatments only, the old Zoladex and the Lupron. These have got names like abiraterone, enzalutamide, darolutamide, apalutamide. And these are oral medications, so they're taken by mouth rather than injection. There have been big advances in chemotherapy use, and the big one that's used is a drug called docetaxel, another one called cabazitaxel. These would be the 2 most common chemotherapy drugs. There's other treatments, being called radium-223, which is a radioactive isotope that can be given by injection, and it goes to any hot areas on a bone scan, delivering radiation that way without treating other parts of the body. And all of these have been shown to improve survival in clinical trials. And there are many, many more agents, which we're not going to talk about, which are currently in the clinical trial stage. When we think about men whose cancer has spread, it's not always this case of the last patient who had cancer all over his body. Often we might find areas of cancer in just 1 or 2 spots. So this is a man I saw recently with Gleason 8 prostate cancer, and the bone scan showing an area of cancer here in his pelvis. This is called oligometastatic cancer. And this seems to behave differently from those who've got more widespread cancer. And it's been shown believe it or not, that giving radiation treatment to the prostate improves survival of these men. So now for men who've got what's called oligometastatic prostate cancer, current advice is to have some of these newer hormone treatments as well as radiation to the prostate. We are exploring whether or not we should also give radiation to the area of cancer spread. And that's something that is being explored in an ongoing Canada-wide national trial that's being led by one of my Sunnybrook colleagues, Dr. Patrick Chung. So to sum up, I think we've come a long way in the past 25 years. And there's no way that in 45 minutes I was going to do any sort of justice to the changes that have taken place over that period of time. Survival has improved for prostate cancer because we're able to pick up cancer at an earlier curable stage because of PSA screening. We've got better local treatments due to advances in technology and earlier use of hormones. We have new treatments for metastatic disease. Where are we going? Well, I think more and more we need to tailor the treatment better to the individual and his cancer. And one way to do that is using what are called genomic classifiers, looking at the gene makeup of each particular cancer. And again, this is something that a couple of my colleagues, Dr. Liu, Dr. Chung, are exploring. What we're doing is we're taking biopsies of prostate, looking at the genetic makeup of it, and also in some cases, growing the individual's cancer in the lab. So by growing the individual man's prostate cancer in the laboratory, we're then able to test it outside his body to see what's going to work, what drugs are going to work, what types of radiation might work best. So this brings us to the whole era of what's called personalized medicine, where instead of giving the same treatment to everybody, and some are going to benefit, some aren't going to benefit, some might just have side effects, we can try to tailor the appropriate treatment, be it chemotherapy, hormone treatment, surgery, different types of radiation, based on the genetic makeup of those particular cancers to better select the treatment for each individual. And this is where we're going. And there's a lot of clinical research happening at the moment to make this happen. So this brings me to an end. So this is a nice evening photograph from our trip to Lake Superior last year. I'm looking forward, like Keith said at the start, getting back up again this summer, away from all this technology that I've been talking about. So thank you for your attention.
Thank you, Dr. Morton. That was a wonderful walk down memory lane, and you brought us straight up to date till today. I don't see any questions in the chat box. So those of you who have questions, please put them in the chat box. And I just want to remind everyone that this presentation was recorded and it will be on our website probably in a week or two. So our website is pcstoronto.ca. I will put it in the chat box, and you'll find videos over there. Maybe one of my colleagues can put the exact link to the video page, but if you do search for videos, you'll find them there. And you'll also see some of the older presentations from Dr. Morton. So when
he was younger, Keith.
Well, you shave your head, so we can't tell. At least with me, you can with the gray hair. While everyone's thinking, Doctor, I have a few questions, so maybe I'll take the liberty of asking these questions. Number one, about SBRT or SABRE. The name has the word stereotactic in it. Does that mean that there are two beams focusing from two different directions?
There are many beams. In fact, there are many more than two. So stereotactic refers to the ability to localize the target in space. So originally it referred to treating brain tumors, where a grid system was used and coordinates in space to get a three-dimensional localization of where you need to treat. So stereotactic doesn't necessarily mean two beams like stereo speakers, but it has to do with sort of the space and how it's done. It involves, like, there's a lot of steps involved with SBRT or SABRE. It involves, first of all, being able to localize where you need to treat very accurately. So we need these really good imaging methods to do that. And then being able to target it. And to help us do that as precisely as possible, we usually, as mentioned, put in some gold seeds into the patient. And with that, it seems to be very safe to deliver these very high doses of radiation from the outside.
Okay, but the LINAC is still a single head LINAC.
There's just the one. Yeah,
one.
The one. Same. It's used. It's actually delivered using the exact same machine.
Okay, the same linear accelerator.
Exact same.
The collimator is same one collimator. Okay, so is it more the software that drives it, or is there more to it in the hardware?
So yeah, I mean, there are some changes. There are some differences in how the radiation can be given, because it's revved up. So if you like, it's the same LINAC, but it's highly tuned. So we turn it into like a sports car. So instead of your like eco model that we'd be using in the past, we fine tune it to be able to deliver these very high doses precisely.
Is PSMA PET scan becoming a standard for locating cancer spread after a surgery procedure before doing radiation?
So the answer is yes, it is becoming a standard. And we're lucky that in Ontario at the moment, there is a funded, what's called a registry study for men who've got rising PSA after prostatectomy. Now, it does depend a little bit on the clinical scenario, but it's a very useful test because it can show us where the cancer might be. And in fact, there is a clinical trial from Emory University in Atlanta. They call it the Empire Clinical Trial, which looked at the value of doing PSMA PET in that very situation. And what it showed is that for men who've got a rising PSA following radical prostatectomy, if they have a PSMA PET and the radiation is then directed just at the areas of spread of the cancer rather than sort of treating blindly, the outcome seems to be improved. So we're lucky it's funded at the moment for men who are willing to take part in this registry study. So their information, their clinical information is gathered and collected and later analyzed.
Are all his patients a part of the statistics gathered for all of Canada, or just the studies from Sunnybrook?
So we only gather patient information, or patient statistics, if you like, on men who consent and who are part of a clinical trial. So if you just walk in to your local cancer center and have treatment, your information, your health information, for privacy reasons, will not be used. Your individual information is not going to be used. But there's some, some of the information, such as like incidence, mortality. This is used, but that doesn't come from the cancer center. These would be central statistics. Again, we wouldn't be identified, for example.
Is there an alternative to PSA in the works?
So for detection of prostate cancer, some people have looked at using MRI of prostate. So it depends on what the purpose of the PSA is. But if the purpose of the PSA was to try to find men who had clinically significant prostate cancer, there's a lot of evidence that we might do better by, instead of doing a PSA, doing an MRI scan. And if the MRI scan is clear, you're good. If the MRI scan shows some abnormality, then that can be targeted for biopsy. So you don't need the whole prostate biopsy, just the abnormal area on the MRI scan. And this is a route that is being explored at the moment. Obviously, there's lots of issues: availability of MRI scanners, cost to the system. Like, I know we grumble about the cost of having to pay for a PSA test, but an MRI scan is much more expensive.
Can brachytherapy be used on reoccurrence after having had external beam radiation for 8 weeks? And I'm assuming that's 18 treatments of Zolodex.
I've treated 2 similar cases this morning already. So the answer is yes. We've just completed a clinical trial looking at you can use either type of brachytherapy. There's a large clinical trial that we took part in Sunnybrook. It was led by my friend and colleague, Dr. Juanita Krupp from Kelowna, where we treated 100 men with LDR brachytherapy who previously had external beam radiation treatment. So at 10 years after what's called salvage brachytherapy, only 5% of them subsequently developed a recurrence back in the prostate. Unfortunately, there is a risk of recurrence elsewhere in the body, and about 20% of them were found to have recurrence elsewhere. But it's certainly a good option. The other option would be to use high dose rate brachytherapy. And again, that's something that we do quite a bit of as what's called salvage after previous external beam.
Would continuous use of Eligard and Zytiga be the only benefit to control prostate cancer? With my cancer is in my prostate and lymph nodes, abdominal lymph nodes.
You know, it's really difficult to give like a specific answer to answer to a specific question like this, because there are many variables, okay? And I don't know the whole picture, and I can't give you individual advice. But I think what I was saying, that, you know, there are these new agents, Zytiga is certainly one of them. There are other treatments, other new agents that are used as well, but I'm not able to give you, you know, a specific recommendation without knowing a lot more about the situation. But there are, I guess, a lot of new treatments. Sometimes we use radiation to lymph nodes as well in this sort of setting. But again, it's difficult to say just from that piece of information.
What is the easiest way to access if metastatic disease has been eradicated following 1 year of ADT, high dose brachytherapy, and 23 fractions of high dose external beam radiation, and PSA is undetectable?
I'm trying to. Sorry, I didn't quite understand the question.
He says, what is the easiest way to access?
Yeah, hi. Hi, Dr. Morton. I just want to know if, how can I find out, one of your colleagues who treated me was, and I started off with a Gleason 9, and my PSA was 94.70. And I saw several specialists. I decided to go with Dr. Loblaw. And one of the other doctors I saw was at Princess Margaret, and he started me on Eligard. So I was on Eligard for 1 year. And then I did the high dose brachy with at Sunnybrook with Dr. Loblaw. A couple of weeks later, I did 23 fractions of high dose external beam. And I'm very happy to say my PSA is undetectable, and I do feel better, but I did have some metastatic disease. And I was wondering, how could I determine if it has been eradicated by those 23 doses of external beam radiation?
So the PSA is usually the best indicator of what's happening afterwards. It's the most sensitive test we have of, whether the cancer is gone, whether it's growing. And like a PSA of 94 with Gleason 9 cancer is pretty high risk initially. And the fact that it's undetectable is really good. And with a non-detectable PSA, it's highly unlikely that any test is going to be able to find prostate cancer.
So I guess I shouldn't go looking for anything, should I?
You know what? I just accept it.
I think it's fabulous. The whole group at Sunnybrook, everyone there was just sensational with me.
Yeah. I mean, if I was in your shoes, Michael, and my PSA was undetectable, I'd just say fantastic, and I wouldn't go looking for trouble, to be honest.
Okay. Thank you very much. That was a great presentation, sir.
Thank you.
If there's a recurrence after brachytherapy, is adding more seeds part of plan B?
We often wouldn't, Noah, we often wouldn't add more seeds later on. First of all, recurrence in the prostate after brachytherapy is really rare, which is good news. If it were to happen, we'd have a very close look and try to figure out where exactly it was. So we'd use some of those scans that we showed earlier. Remember the MRI and the PET scan to try to figure out where the cancer might be, and then we try to figure out what options might exist. But often, if it were to come back, the most common scenario is very small area of recurrence, maybe on the edge of where it was treated. And we can often go back and treat not with more seeds, but with that other type of brachytherapy we talked about, the high dose rate brachytherapy.
Is there research on use of viruses to deal with prostate cancer where only cancer cells are killed? Yes,
is the answer. It's at these are very early stages, Bob. There's a lot of interest in doing a few different things with viruses. One is using them to spark the body's immune system. Okay, so like immune therapy. So if you could put something into cancer cells that would appear to the body as foreign and then recruit the body's immune system to treat it, that's one really good approach. So
I was found to have high-grade prostate cancer.
He's 21 years out after brachytherapy. Is he still correct in getting PSAs once a year?
I've tried to stop you, Aaron, and it's been impossible.
Yeah, I keep fighting that.
Yeah, I know. I think, if someone's 21 years out and their PSA is still pretty much zero, I think it's safe to say you're not going to die of prostate cancer.
I'm just afraid to say that, period. That's all.
I know. Yep.
When will genome-specific treatment become the norm? In other words, regular treatment?
So at the moment, there is a lot of research going on looking at measuring what's called genomic classifiers. There's a whole... I think someone's dog or cat is being fed. But so there's a lot of research on trying to better characterize the cancer. So where it's at the moment is trying to say, well, if you've got a particular genomic, what's called genomic profile, we should do this. If it's a different one, we should do the other. So at the moment, there's a lot of big clinical trials. I belong to what's called the NRG. It's a big US or North American-wide research group. And we've a big range of studies trying to tease out these and trying to figure out how best to use these genomic classifiers and how to use these to predict which treatment might be best to use. But it's at an early stage. It's going to take more years. It's going to take another 5 years, I think, before we have answers.
You have heard about the MRI-guided transurethral ultrasound therapy, TULSA Pro.
So this is technology that once again originated in Sunnybrook. So this is Sunnybrook treatment, which has been developed by some industries and is taking off, particularly in the States. So yes is the answer to that. This is a form of HIFU, so it uses high frequency ultrasound that's delivered through the urethra to ablate areas of prostate cancer.
So do you carry out that at Sunnybrook now? Or?
So Dr. Laurie Klotz is one of the main inventors of this approach. It was due to start in Sunnybrook any day now. I know last time I spoke to Dr. Klotz, he was expecting it to be up and running in early April. So I think the truthful answer is we don't do it yet. It's been done up to now as part of a clinical trial that was used to, develop this treatment and get approval for it. But it's something that will be available through Dr. Klotz in the very near future.
Okay.
Asking if there's any way to deal with hot flashes other than prescription medications.
Oh, I wish there was. I wish there was, Barry. I know this is awful. The people do vary, and I have some men who don't have too much trouble, and some people whose lives are total misery as a result of hot flashes, and it causes them to stop even taking the hormone treatment. It's a big problem. Like, we've tried all sorts of things over the years: oil of primrose, vitamin E. Some people find these helpful, but unfortunately, there's not a lot that can be done without resorting to some prescription medication.
There are a lot of questions so far have been on new technologies, new treatments, things like that. And I'm sure a lot of them on trials. Dr. Morton, is there, other than clinicaltrials.gov, is there any other site that people can go to look for what trials are going on?
Well, clinicaltrials.gov is the best site because all reputable clinical trials are going to be registered on that site. So that's a requirement when you open a clinical trial to register it on that site. So that's going to be the most comprehensive way of finding particular clinical trials.
For how long does radiation continue to work after external beam radiation? So,
radiation works in milliseconds, okay, after it's given. So there's a whole stream of events that start taking place when someone has radiation treatment. Radiation works by upsetting the DNA in the actual cancer cells, and that happens almost instantaneously. But the effects of that disruption of DNA can take quite some time to manifest itself. And the easiest analogy that I can think of is it's a bit like cutting the roots of a tree, okay? So you have the treatment, the tree, you cut the roots, the tree is still standing. It looks as if it's still alive, but it's not. It's dead, except it doesn't know it yet, okay? And that's what happens to the cancer after radiation treatment. It's dead, but it might still be present physically, but it's a dead cancer. It's not able to do anything. What it's doing is it's slowly dying and slowly disappearing from the body, from the prostate. And that's manifest by the slow decrease in the PSA that happens after treatment. So after someone has had radiation treatment, be it brachytherapy or external beam, immediately after treatment, the cancer is still there, hasn't moved, it's still there. If you biopsy, you're still going to find it, but it's dead cancer. And the body's immune system will then come in and mop it up. But it takes a while for that to happen. And it does take often several years, for the PSA to reach its lowest value after treatment, because the cancer is still dying and still being, if you like, dissolved and absorbed by the body's immune system over that length of time.
Would stem cell treatment be something similar to DNA treatment?
So we're not really using DNA treatment. What we've been talking about is looking at the DNA of the cancer to identify how the cancer is going to behave and identify which treatments might be most suited for it. So that's sort of where we're at with in terms of DNA or genomics. There's different words for these, but this would be like this genomic classifier. These measuring having a good look at the DNA of the cancer cells. Now, we don't really use DNA to treat prostate cancer, but stem cell treatment. There's the most common use of stem cells would be in blood type malignancies. So we're talking about leukemias, lymphomas, where you take someone's blood stem cells and then transfuse it back into them. That's something that we wouldn't use for prostate cancer.
So that seems like the last question that I have on the list. I've put the link to our videos on the chat box, and Dr. Morton's video of Dr. Morton's presentation today will be there up in a week or so. Just a comment, Doctor, when you show images of external beam radiation, they're always with a man with a prostate. And quite a few of us have had salvage radiotherapy. So, maybe next time when you speak to us, if you could toss in a slide or two of someone who's doing salvage radiotherapy.
It will look very similar.
Without the black circle in the middle. So, okay. So that's, we're letting Dr. Morton off quite easily today. There were a lot of questions. Thanks to all the men who asked your questions. Thanks to all of you for attending today and taking part in it. Please make note of the address, those of you who want to look at the videos. And there are a lot of messages in the chat box of thanks to you, Dr. Morton. Some of them have had to leave, but they've said they've enjoyed the talk so far. I just want to remind everyone that our next awareness night is on Wednesday, the 26th of May at 7 o'clock in the evening. And our speaker is Dr. Andrew Matthew, who is a clinical psychologist at Princess Margaret Cancer Center. So he's going to talk about, I guess, the psychological aspects of dealing with prostate cancer and the side effects after treatment. So thanks very much, Dr. Morton, for your time. Thanks for taking 2 hours out of your busy day and probably evenings when you relax after a long day to talk to us. And it was great. It was very informative. And it was nice for some of us like me, who I've only been involved in prostate cancer treatments for the last 5 years, to see what happened before my time. And quite enlightening. So thanks very much for your time and your presentation. And to everyone, a special donation will be made in Dr. Morton's name to his favorite charity, which is the Daily Bread Food Bank. So thanks a lot, everyone. Thanks, Dr. Morton.
Thank you.
And hope to see you again soon, and hope to see you in person rather than on Zoom.
Thanks, everybody. Great to see everybody. Thanks for the invitation. It's great to see some old friends here. Even
Thanks,
if it's
Bob.
And hope to see you at the North York General Clinic soon.
Let's hope.
I haven't seen you there for a year. Yeah.
For sure.
Bye for now.